Now, why should we focus on hypertension in pregnancy? We see that about 15 to 20% of maternal deaths in India are still due to hypertensive disorders, and most of them, I say most, not all, not 100%, but most of them can be prevented if we do proper screening, proper treatment, and timely intervention. And it's basically eclampsia which is the killer. It is mostly due to late detection, delayed treatment, and lack of preparedness to manage these emergencies. Now coming to the burden in India, pregnancy-induced hypertension, it affects about 10% of pregnancies, while preeclampsia is seen in 5 to 8% of pregnancies. Eclampsia affects 1.5% of institutional deliveries, because we don't have the record of the eclampsia patients that are delivered or what happens to them in the peripheries or which go unreported. And this is seen more in unbooked patients, the rural population who don't have access to the medical system, the adolescent girls, and the anemic women. Let's revise what are the hypertensive disorders of pregnancy. We all know the first is gestational hypertension. Then coming to the next severe form is preeclampsia, and eclampsia is the severest form. Then we have the chronic hypertension and superimposed preeclampsia. A quick revision of the definitions. Gestational hypertension is blood pressure of more than equal to 140/90, detected beyond 20 weeks of gestation, and which returns to normal within 42 days postpartum. And there are no associated any other features of preeclampsia. While chronic hypertension, it's a known case of hypertension or a case of hypertension detected before 20 weeks of gestation in absence of any neoplastic, trophoblastic disease and multiple pregnancies. While coming to preeclampsia, it is a multi-system inflammatory disorder beyond 20 weeks of pregnancy with significant proteinuria characterized by de novo onset of hypertension, and more recently we have atypical presentation also of preeclampsia, in which we may not see proteinuria, but which we may see neurological symptoms, hematological symptoms, hepatic, renal manifestations, or even fetal growth retardations. And eclampsia, this is the occurrence of seizures in association with preeclampsia. It may occur in absence of preeclampsia also, the atypical presentation. Then superimposed preeclampsia, it is the occurrence of preeclampsia in women with chronic hypertension. And to confirm, the blood pressure reading should be taken 4 to 6 hours with gap so that we can diagnose or label a patient as PIH or hypertensive. Now, why do we see the missed opportunities? The time of onset, when we can miss such patients. 80% of eclampsia cases occur in third trimester or intrapartum. 20% may occur postpartum. And it is the missed screening in the antenatal visits which leads to all the mortality and morbidity. Warning signs which have to be seen with every antenatal visit. We have to ask for severe headache, any blurring of vision, any upper abdominal pain, sudden swelling in the feet or all the body, and the fetal movements. These symptoms and signs have to be asked and seen at every antenatal visit of the patient, along with the urine albumin. Path to mortality. Why do we have mortality in hypertensive disorders? Because of missing these symptoms and signs. Either we don't see the BP, or the BP is taken by the staff and we don't recheck, or we just rely on the staff that whatever he writes is okay. So false or no recording of the BP is the main thing. Then proteinuria has to be checked at every antenatal visit. Symptoms, the patient, if they give symptoms, they should not be ignored. The patient should be investigated and further. And fourth is the non-availability or non-use of magnesium sulfate, which is more important. And fifth, last is the referral in the delay or transport failure of the patients who are in emergencies. Simple preventive protocols which can prevent is a careful and detailed history, blood pressure and urine albumin check in each visit, check symptom list every time the patient comes to us, monitor the fetal growth and amniotic fluid volume, and use of Doppler if available and when needed. Now coming to this very important gestosis score, which has been developed by Dr. Gorak and his team, and it is a very useful scoring system. It can be kept on our tables, and every time the patient visits to us, we should go through all these scoring systems. And any patient which has a score of more than or equal to 3 is at high risk of preeclampsia. So as soon as we see that the patient is at high risk of preeclampsia, we should start the treatment First of all, once the gestosis score has been done and we've labeled the patient as a high risk, we start on a low carbohydrate diet and start aspirin. Aspirin 75 milligram can be started even at the first visit. We don't wait for the second trimester or even at the first visit before as soon as the placentation starts. Calcium 1 gram has to be given. Antihypertensive to be started whenever we record a BP of 140/90. And Maxelf has to be given in all severe hypertensive disorders and in eclampsia. Early referral to higher center is the key to preventing maternal mortality. The magnesium sulfate is the lifesaver and we all should be aware of it at the doses and the mechanism of action. A loading dose can prevent 90% of eclamptic seizures. In case we are referring a patient or transferring the patient, the loading dose has to be given before we transfer the patient. First dose can be given IM by all, even at the sub-center level. All healthcare workers should be made aware and trained in giving this Maxelf. It should be included in the obstetric emergency kits of all the centers. The golden opportunity, first contact have to be trained. All the ASHA workers, the ANMs have to be told about the danger signs. BP and albumin levels should be done even at village levels, at the small centers. And all high-risk women should be flagged. A red mark should be pasted on the antenatal cards so that no one else misses the patient. We have learned that when we follow these protocols, Tamil Nadu state has got the eclampsia-related deaths reduced by 70% because they follow strict ANC protocols. All the NMs and staff nurses are trained, and early magnesium sulfate is used in all patients who require. It's available at all the primary health centers in Tamil Nadu. Similar is the case for Kerala, which has 100% BP monitoring, urine albumin, and emergency kits available with them. Delay. Where do we see the delay? Why do the patients land up in emergency and eclampsia? Delay 1 is in recognizing the severity. Delay 2 in reaching the facility. So we have to upgrade our transport system so that the patient reaches the facility in time. And delay 3 is at facility. The patient, if reaches the center, the staff and the doctors should be trained in giving the obstetric emergency treatment, and the obstetric emergency kit should be available at all the centers. Zero eclampsia strategy, 5 pillars: screening at first ANC, early detection of preeclampsia, timely magnesium sulfate, monitoring and timely delivery, and postpartum BP checks for at least a week. Must have protocols for all centers at all levels. At the sub-center level, we should be having BP and urine albumin. Magnesium sulfate should be available, early referral when required. At the primary health centers, patient can be admitted, managed, and delivered, and if required, referral to a higher center. All the district hospitals should have an ICU, HDU, and hypertensive and super specialist or specialist to manage such patients. HDU in every district is a must. Dedicated maternal HD unit, availability of magnesium sulfate, labetalol, nifedipine, a full-fledged laboratory, availability of specialists, and protocol for link to referral units is a must in all districts so that we can bring down the maternal mortality in eclampsia. All mothers at high risk should be tracked. A red sticker has to be placed on the antenatal cards, and follow-up to be done till 42 days postpartum to see for any postpartum hypertension. All the obstetricians, doctors, ANMs should be trained. All eclampsia kits should be available, and regular CMEs like the one we are having has to be done so that we revise what we learn. So the mission for us is in target 2027, zero eclampsia in our country. For 2025, we have at least 50% reduction in eclampsia deaths, and the goal for 2027, no woman to die of eclampsia. We have to involve DGF, IMA, FOXY, other state governments in helping improving a maternal mortality due to eclampsia. So call to action, eclampsia is a failure of the system, not the woman. Let us make BP monitoring and magnesium sulfate availability non-negotiable. Each life saved is a proof that our system works. Thank you.